Hey, welcome back to the Healthcare Nation podcast. I'm Rick Chinada, and today we're taking a clear-eyed look at the most consequential shifts happening across healthcare and what this means for policy, for payers, and for the delivery system that millions of Americans still depend upon. This isn't about fringe developments. It's about structural changes that are moving faster than CMS, faster than the regulatory environment, and certainly faster than most operators are prepared for. And to help us make sense of all of it, we're once again joined by someone whose work I trust deeply, Emily Evans, Managing Director of Healthcare Policy at Hedgeye. Emily has spent her career analyzing the intersections of regulation, economics, and political risk, the parts of the system that actually determine what becomes real and what stays theoretical. We're going to cut through the noise and get to the structural signals, who it affects, who stands to win or lose, and what leaders should be preparing for now. Welcome to the Healthcare Nation podcast.
Welcome to the Healthcare Nation podcast. We're committed to bringing you thought leaders in the field to discuss what's new and noteworthy in the healthcare sector. Now your host, Rick Chinada.
Okay, welcome back to the Healthcare Nation podcast. Again, Emily Evans, one of our favorite guests, a frequent flyer. And as I've said, you're like our in residence, hedge fund market policy person. I hope you don't mind that moniker, Emily, because you got it.
No, I don't at all. You should also add contrarian.
Oh, I want you to be the contrarian. That's what we're looking for, that perspective. And we're always trying to be balanced here, but we've got to keep the the hot sauce in there to spice things up. So contrarian perspectives always welcome. And we got a lot to talk about too today.
We certainly do.
So let me jump in. I want to start maybe more at a macro level. And although I'd like to thematically talk about a lot of different things, in direct to consumer, regulation, markets, but I want to start with system level shifts, Emily. From a macro perspective, what do you think is the single most important structural change that is happening right now in U.S. healthcare? Something that policymakers, investors, and others are not, if I could characterize it this way, are not fully pricing in.
Direct to consumer. Now, the White House is very aware of this, and they're orchestrating some of it. But the most important of these is the emergence of a drug channel that works its way around the middlemen, as they call them, but it's the group purchasing organizations, the wholesalers, and of course the now nefarious pharmacy benefit managers. Mm-hmm. That would be, and I don't think it's quite baked into companies like McKesson or Cardinal Health, but it also isn't baked into the idea of like Novo Nordisk stock is taking a hit. And it's not a very well-known brand, right? You don't think, I need to go buy this by Novo. Lilly, on the other hand, is a world-class American brand. And if you're going direct to consumer, you want to have a good brand. So, so I think it's not underappreciated how much upside there is for a good pharmaceutical brand company and how much downside there is for off brands and also for the drug channel and for hospitals and so forth. When you start cutting out all of these layers they're just rent seekers now.
Okay. So Emily, what I'm hearing, let me just feed that back to you. When you think about that, the, pharma digital health platforms moving closer to the consumer, is this a case of prescribing, fulfillment, adherence, all of that, like a vertically integrated, path?
Yes, because what your local pharmacy exists because you had to take a little piece of paper, and that your doctor gave you, and you take that into the pharmacy and you trade that for a drug. And we solved that with e-prescribing. E-prescribing became mandatory, so it goes directly to your pharmacy. There's no reason why I can't go to Lilly or AbbVie or any other drug company, as long as they want an order. That's what they want. and how they fulfill, there's all these options that there wasn't 20 years ago. And even, Amazon could fulfill. So it's the barriers that existed. And I about 6 months ago, I said, okay, the barrier to all of this is the physician's order. How do you get the physician's order to the pharmacy or the pharmacist? Because every other problem has been solved with e-prescribing and mail order and so forth. And the answer is that Lilly partners with a company, and your physician now can send the order directly to Lilly. So they've solved that.
And I may be getting this wrong, but at least from what I've seen demographically, and with I'll just call it digital first, younger millennials, Gen X, Gen Z, the way they have much more expectation with respect to agency over their own healthcare, that the whole consumer side of this, starting with the pharma piece, but extending way beyond that, is going to get more than traction. It's probably going to be an aspect of the new model of care moving forward.
I think so. We're watching wellness movement converge with, the farm, like in compounding. That's where it went first, right? Because it's, kind of off the grid, so to speak. But wellness converging with pharmaceuticals and fitness and physical therapy, those things are all kind of moving together and starting to become what everybody's been talking about for decades, which is a holistic approach to human health. And that's
and let me jump on that for a second, because I'm working with some folks right now who are entering in, and in fact, one established company in the UK that is already deep in the longevity space. And they shared with me the longevity company. They said, we're right on the edge of, I don't want to, these are my words, not theirs, of legitimacy with respect to the established, at least in the United States, scientific medical establishment looking at longevity as something that's going to be inculcated into the system. It's slowly kind of blending. Do you see that? And is that what you're inferring there? That there's going to be this kind of crossover, this, mix up between the two? Because I think that would be a good thing.
Yeah. Oh, I think it's a very positive thing. And this is one of the messages of the MAHA movement, make America healthy again. We can fight over Medicare spending and Medicaid spending and so forth, but there is nothing more powerful than convincing people to take better care of themselves. Because if they take better care of themselves, they're going to need less health care, and your spending goes down, right? So it's public policy for one, and it's clear what we're doing isn't working.
Yeah,
we can't argue about that. So I think that and there's a lot of hokum in there, right? There's a lot of, you do this and, you live 10 years longer. And, one of those big longevity guys, looks like he's been dead for 10 years. But there is within that a lot of very important messages about exercise and weight, how much you weigh, and how your, heart is functioning and your lungs and so forth. That'll be powerful messages. It's very bad news for something like, the Cheesecake Factory, right. which serves up about 5,000 calories a meal.
Right. And let me jump on we'll say the GLPs and the weight piece and the obesity piece. I just read today, I think that the oral, maybe it's Novo's, I can't remember who is developing the Novo, that it did not give good results with respect to Alzheimer's. They were hoping, or dementia. They were hoping some benefit from there, which, by the way, I think as amazing as GLPs are we really expect them to be a cure-all for everything? And
I know.
Is it too much hype? Is there a bubble around this? And what's happening in the space, and how's the market, responding to that?
Well, Lilly just hit 1 trillion, but touched 1 trillion in market cap earlier in the week, and it's doing well. Novo's having a much more difficult time. And when you get into these smaller pharmaceutical companies, they tend to push the envelope on things a bit more. You saw this with Moderna and some of their cancer vaccines and so forth. They tend to, and they dish out a lot of, oh, we're going to do these great things. And that's why you want to support our stock price. Whereas the really big guys like Lilly, they take a much, more cautious approach to their clinical programs and making sure that they're, exploring things that they think can work. Because they have a lot more reputation to lose than a smaller company. But I think, there's the theory that Alzheimer's has a big metabolic component. I could see why they would want to explore, but yeah, it doesn't look like they're going to get any traction on that anytime soon.
Yeah, and clinically, things are still early. We don't have 10 years worth of data, at least at scale, like what we're seeing with respect to the uptake clinically, right? That's a reality. But let me ask you this: when you think about system level effects, and I'm really sticking with the GLPs, you think about Medicaid, state budgets. What's the fiscal exposure looking at along those lines? CMS and what's happening along those lines with respect to the administration's, push to cover this?
The administration's push to cover it has been contingent on the price, and I've said this for a year and a half now. It's like it's the price, and the resistance to the drug because it came out of the box at like $1,200 a month, which is the biggest consumers of GLP-1 drugs are on the Upper East Side of Manhattan. Yeah. And so the price is the issue. So the trade-off here with the administration has been, if you can get that price into something normal land, and now Lilly's at $350 for a vial. When they roll out the oral, they'll charge $150 a month, which is in the zone, right? It's not a crazy number anymore, like $1,200. So their game. The White House has been like, okay, get the price down, and we'll expand coverage. That's going to be the trade-off, and that's exactly what's going on. And I think they're going to be very successful with it.
Yeah, and this is extrapolation. Obviously, I'm not making throwing out a clinical opinion on this. But if you were going to trade off your diabetic drugs, if you're a type 2 diabetic for, a pill, that would be, incredible if you're thinking about an individual's, again, ability to change the trajectory of their health status.
Exactly. And that's the trade-offs are fairly significant. So you spend $150 a month and you cut your food consumed outside the home, which is where so much of the food that's really not great for you is consumed. You've got you could have a very nice cost benefit to the monthly budget. And then of course, if you're looking at the federal ledger, you're looking at less treatment for cardiovascular disease. You're looking at, less expensive treatments for diabetes. You can do that. Now, we rarely do that in this country. Right. But again, back to the whole MAHA movement, the whole message is, everybody get healthy, be healthy. We want to help you be healthy. And these, you'll enjoy life more. And we, the federal government, will spend less money on you.
Yeah. And on that theme, right? I want control over my own health. I want agency. I want to leverage technology to put me in touch, have better access. It gets back to that direct to consumer side. And if I was going to, and look, I grew up in hospitals and the health system, so I've got to come from this perspective as well. Are we siphoning off profitable revenue, volumes, everything, obviously weight management, but more than that, even primary care, chronic disease support? What happens to the established health system financial model? Is the healthcare delivery system as it exists today prepared for this? And what's the push and pull that fills that gap?
Yeah, and the answer is, are they prepared? No, I don't think they are, and I think there's a number of other movements that they really need to embrace. The agency over your health, that holistic, that's a function of not just technology and advances in that. That's a function too of demographics. And the healthcare system in America was built for the population that was born between 1945 and 1961. And that's what it is. Everything about it was built for that group of people who were anomalous in their size. You've never seen the kind of, the change in the birth rate between, say, 1940 and 1945. It just doesn't exist in normal population dynamic. And so the system had to accommodate that, and it was built out to accommodate that. And now in 2027, you'll see the last of that cohort age into Medicare, right. Which of course I'm equating with highest utilization years. So that's the proxy I'm using. But the system that, what's happening is your average, hospital administrator is like, oh, America's aging. Like, well, you can't keep saying that forever. Right. I mean, at some point you have to recognize that the population is going to change, and that's what it's doing.
Yeah. And the other thing, America's aging, but the number of people required to pay for that aging group has shrunk over the course of, 50 years. Right.
Yeah. So you see that in many ways, and I think it's going to be a few difficult years because your 1947 cohort, which is the biggest one, that they are 79 next year. So they're deep into their high expenditure years. And you're seeing this when you talk about like Medicare Advantage plans, Humana, they're all reporting higher utilization. And that's because, once you hit 75 and things start breaking, you're getting, more healthcare and more expensive healthcare. But once we're through that, which is not very long, far, you've got a system that's going to have to accommodate a very different mindset with respect to health.
Yeah. So look, we can agree the system, healthcare is evolving faster than the governance structures that have been built historically stood up to really, have it function. This misalignment as we move forward, how is it playing out with respect to the market and the rule book? What risks is this creating?
Risks. I think the risk is that I don't know that there's risks to, say, human health. Although I'm sure there's some of that. But I think the biggest risk is to the command and control, centrally planned structure of public health and American healthcare system. So a lot of this broke during the public health emergency between 20 and 23. But there's the system where that says, okay, you will buy a health plan, with these scope of benefits, and you will, pay your employer this much of your paycheck every month. And I think that's is being rejected and will continue to be rejected while people look for where the value is in the system. Where do I get the most benefit by engaging in this system? Not because somebody tells me to, but because I think it's valuable. And that's why you've seen companies like Hims with their compounding, drug, which is something to, worth examining another day. But also, what's their message? Their message is, take control. And here's some things. It's weight loss. It's the hormone replacement therapy. They're right on the front edge of that. So those things are, they're successful because people find value in it. Yeah. And not because they're told, but because they do.
Right. But Emily, let me pick up on that theme. So when I look at Roman and Hims and Hers and everything else that's going on these platforms, it gets back to what I was saying earlier with the demographics, right? The younger population, Gen Z, Gen X, younger. And I think leveraging of technology, absolutely the redefining of how they want their access to healthcare. But the other piece is the source of truth, right? I mean, where do they get their information from?
Yeah.
Who's literally influencing them with respect to what's real, what's not? And we end up having this bureaucratic battle going on over, our state institutions and whether they are even places we should go to for credible, valid, information.
Right. Well, I hope that is a passing problem. I tend to think that people who go into science, for example, in public health, are generally sincere, in their desires to help others. I think where it might need a little fixing is the quality of research, the quality of published research, which the FDA is, I think, trying to fix. They're getting way too much blowback for what I think is a very sincere effort to fix a very big problem. And I think NIH is doing some of the same thing. I don't think people like to go into medicine or science, to be fraudsters. There are some people like that, but I don't think that's most people, probably not even a significant amount of people. But people, so the increased value of the research, if they are successful at NIH and FDA, I think will help a good bit. Getting the pharmaceutical ads off the air probably help a little bit too, because it is, it's so silly, right? It doesn't give you a good picture of what you need to know. And there's all these Substacks out there that'll explain things in better detail. So that's where people I hope will go, and they'll gravitate to things that make sense. I hope. But yeah, there's going to be some mistakes. Yeah. I don't think you can deny that that's going to happen. But yeah. When they did what they did during the public health emergency and acted so irrationally in some regards, what do you expect, right?
Yeah. So, look, it gets back to, I'll call them blind spots, institutional, regulatory. If I think of it this way, folks they're out of sync at those levels of, again, I'm thinking government here.
Oh, yes.
And whether it's the FDA, CMS, even the FTC, I mean, that's one whole group, as well as, I would say, great, maybe leave the private sector and the innovative side of the markets to deal with new models of care, breakthroughs, everything we're going to have to contend with because of things like clinician shortages, the advance of technology, et cetera. But the moonshots, we should probably have the government playing some part in the funding of that. Yeah. And then the regulatory side to try to keep up with this new world. Tell me your thoughts on that.
Well, and Senator Bill Cassidy has brought this up, and various NIH leaders have brought it up, is the focus for the federal government should be on basic research, the stuff for which there isn't really a market return visible, in that 3 to 5 year window. And they have pledged that we're going to be focused more on basic research. And I think that Congress understands that when they get into translational work at NIH, they're really competing and pushing out the private sector. And therefore, a lot of decisions get made or a lot of research gets done. This is back to kind of the fraudster problem. A lot of research gets done that maybe shouldn't have. And like the amyloid beta thesis for Alzheimer's being a great example of a mistake. And over at the FDA, you see them focusing on orphan and rare diseases, and which are not, don't lend themselves, although there's a lot of private market activity there, but they're hard to make a return on. And so
Right.
what's the FDA's response? Let's make this as easy as possible and recognize that these are very difficult situations when you have a disease that affects 100,000 people worldwide. That's a tough thing. You need all the support you can get. So it's two different ways of supporting that approach. But I think I think that's what they've said, and I take them at their word that that's what they're trying to do. I mean, we don't need another study on whether red wine is good for you or bad for you. Or name your other cockamamie nutritional study that's been coming out of these research centers for years.
But we probably do need someone to weigh in from, I'm just going to say both sides, and the both sides, folks can interpret what that means. I don't necessarily mean it politically. On something like statins, when you're saying, hey, should I take a statin? Should I not? Every time I'm looking at my feed, it's saying I got a group of people saying, no, these are the negatives. And you've got, then these, cardiologists who are clearly could be perceived from another generation saying, no, this is the difference it's made. Who knows? I mean, this is, I think, what folks are contending with nowadays, and it's creating such a level of contention in just the narrative between, science.
And 30 years ago, you would go to your doctor and he prescribed statins, and let's use statins as an example. I think the rub on statins is that they may strip cholesterol out of parts of your body you don't want it stripped out of, like your brain. Right. And that has led to not an
unconsequential outcome with that. Right?
Yeah, right. Yeah, because there's a portion of people who take them who experience some memory loss and some cognitive deterioration. Supposedly, we don't have that. Right. We don't have that research. But 30 years ago, you go to your doctor and he'd be like, I'm going to put you on statins. Now, here's the deal. If you have any signs of memory loss or anything like that, I want to know that right away, because there's some portion of this population that's experienced that. And then the doctor can behave. He can do what he needs to do, right? He can treat the patient. And because of the way in which we make these primary care physicians see their patients in 7-minute windows, and they're grinding through their day, they've come to rely on whatever the pharmaceutical industry has told, whatever the pharmaceutical, it's a shortcut to understanding what the drug does. And you miss some of those risk factors in managing the patient, and then on the flip side of it, hormone replacement therapy, which was, came off the market in 2012, it experienced a fairly nice run of being therapeutic, and all of a sudden everyone's like, oh no, you're going to have a heart attack.
And I think there was the numbers pre-regulation, if I could call it that, on HRT, it was tremendous numbers, like large numbers, maybe, I don't even know, 1 out of 4. Then it went down to 0 after the guidelines were changed, right? Something like that. When this whiplash is making folks again question the source of truth in our institutions.
Right. And I think that, if HRT's got these benefits, and I haven't read any of the work that McCary has talked about, but if they have all these benefits, why were you keeping that off the market? Right. Why did you have a flawed study on that hand? And then on the other hand is, the stuff that's on the market that it maybe, should require a closer monitoring. Like, I want to know if you're having any cognitive problems. And you're going to come in and see me, with that. Yeah. But that's what leaves people to go looking for that information on their own, is because the person they should count on, their primary care physician, if they got one, doesn't have time to talk to them about that, or doesn't have time to understand that issue.
And I hate to say it, maybe teaching to the test, with respect to numbers.
Yeah. Well, and statins, it kind of have cheated too. Statins are is a Medicare quality measure. Did you talk to the patient about statins, or did you prescribe statins? I mean, come on. that should not define how you get paid. Whether or not you prescribe statins, and that's the kind of nonsense that is got to come out of the system.
We've made that mistake before. I think I've mentioned it on the podcast with respect to, I'll just say the opioid crisis and having pain as one of the vital signs. And it was like, oh no, everyone should be out of pain after surgery. If not, it looks bad on me, the surgeon. So the best way to do that is let me prescribe you some Oxy. And that just is crazy when, at least when I started out clinically years ago, it was not unusual. Then you'd say to patients, look, the first day it is going to hurt really, really bad. It is going to hurt the heck out of you. And guess what? Every day that pain should get a little less, but that's normal instead of saying it will numb you. And that's what your expectation should be.
Yeah. Yeah. I mean, we're recounting all these crazy things. Who wouldn't be suspicious, right? Who wouldn't want to go, And the lack of primary, the sort of deterioration of the practice of primary care, is making it, just compounding the mistakes.
Yeah. Let me bring it back to the here and now. Literally, I mean, when I think about this, ACA subsidies, the enhanced ones set to expire the end of 2025. So much going on back and forth. Even today, reading about the administration coming forth with a plan, I think there's some thought of it being extended for 2 years while the GOP works on their new formula for healthcare. As it's affecting what we're seeing, Emily, everything, access, risk pools, budgets, individuals, the markets. I mean, it's freaking me out. I know, Joe, our producer, it's freaking, our last podcast, we talked about serious and significant, hits that folks are anticipating taking.
Yes, and one of the enhanced premium tax subsidies, which is what's in play here, not all the tax subsidies, but the enhanced premium. And what they did is they lowered effectively to zero the premium for people between 100%, 250% of federal poverty level. A lot of them being in the 100 to 150% federal poverty level. It also added as a benefit the availability of tax subsidies for people making over 400% of the federal poverty level. And that last one hasn't really moved the needle that much on population. There's about 1.5 million people in that bucket. And so it's not like it's, and some of those people were enrolled before because they have access through healthcare.gov, even if they didn't get tax subsidy. So the challenge, and what is happening is there are two problems. The first problem is that the people who don't have a premium aren't engaged in whether or not they are enrolled. Nothing comes out of their bank account, nothing shows up on their credit card. And the amount of fraud in the system is fairly significant, especially between 100 and 150% of federal poverty level. Then on the other hand, you have a lot of 1.5 million people who are, sole contractors, they're self-employed, and they have enrolled in this system, and they're going to experience a fairly significant price shock because they're no longer going to have a subsidy that gets the price of those premiums to 8.5% of their income. What I expect to happen is that there probably won't be an extension. While the Senate is interested in some compromise, the House is not.
Right.
And I don't really see a path. The fact that the White House was supposedly proposing something, maybe that was true, maybe it wasn't. It was just showed up in a Politico article, and I never heard anything coming out of anybody in the White House to suggest it was true. And it got shot. If it was true, it got shot down pretty quickly by the House side. The fact of the matter is that every single thing Congress does with healthcare is pretty bad. I mean, they can't seem to come up with policies that aren't in the end egregious. And that's true of the Affordable Care Act is, EMTALA, EMTALA's had all these consequences that reverberate. Part D drugs, great program, but nobody paid attention to what it was doing to list prices.
Right.
See, so there's this, I'm writing this article about the exchanges, and the opening line is America hide your wallet, because, for the 1.5 million people that, may benefit at 400% or more of the federal poverty level, you have all these distortions that are causing problems for everybody else.
And that's, isn't it also true? The reality is that the policymakers, the authors of these policies, it sounds great when it's unfolded, but they fail to communicate that there is an expiration date on that, and have the sense of urgency to have, in advance of that expiration date, have something else in place.
Yeah. And what I think the game plan is, all right, we'll extend these and everybody will go along with another extension, or we'll make this a big issue for, and when those extensions, when the enhanced premiums tax credits went into effect, I think there's a lot of confidence that Joe Biden would serve another term, and both in 21 and 22. They were not expecting the electoral outcome that they got. So that was part of the miscalculation. And then the second part of the miscalculation was with the shutdown. Okay, let's have a shutdown and we can make healthcare an issue. And I have this chart of Google Trends, like people searching for, and the things people cared the most about, these three things, the shutdown, ACA exchange premiums, your flight plans, your travel plans, and SNAP benefits. The Affordable Care Act barely registers. It's people wanted to know if the plane was going to take off.
Yeah.
Because they had somewhere to go, or they were worried about their SNAP benefits. And so back to that demographic thing we're talking about, are the people that are paying attention and voting and concerned, are they the people that they were 15 years ago or 10 years ago? And I think the answer is no, this is a different population, and they're sort of like, whatever, or I want to know about my travel plans.
Right. Let me pivot a little bit now and bring it home with things that I always love talking about, and I think you do too, and that is what's happening with innovation, what's going on in the markets, investors, signals. Are there any, I'll say, indicators, even early indicators of meaningful change coming out of the private sector, out of the markets, from capital flows, even regulatory actions that we're seeing that are in sync with the consumer behavior that you just mentioned and that we're talking about, that is hopeful, or that we should say, wow, whether it's AI with, kind of the breakthroughs on the biotech, medtech, drug side? What are you seeing on the investor signal side that kind of brings that all together?
I would say first of all, the biotech is getting its mojo back, and I think it will continue. It had to make a turn. It was dug in on a lot of different things that aren't going to yield anything. Like the mRNA platform is not going to yield everything that people thought it was going to yield. The amyloid thesis is not yielding results. There are lots of things like that, and they've had to make this adjustment, and they've had to make that adjustment without the benefit of NIH, free money, and they've had to make that adjustment without a lot of money pouring into 25 or 30 big academic institutions here in the United States. And as it rolls forward, go back to what I said. People go into these fields because they are curious people who want to solve big problems. They're not shysters. They're not fraudsters. So I think we are making that turn, and we're going to continue to make that turn. There's still a lot of things that need to be ironed out in terms of the systems. There were a lot of people inside these organizations that did not want anything to change. They thought everything was fine. And I mean, you can look at you look at a lot of things and go, no, everything's not fine. I mean, the data on longevity and obesity and mortality is terrible.
Right.
And so
compared to other industrialized countries, it's just, it's nothing.
You can't be proud of any of it. And, so I think we're going to see that. And if Lilly is successful and is followed by other big pharma, Johnson & Johnson, I think, is working on a platform. If they are successful in talking directly to their consumers, hopefully with the help of a doctor, okay, who can balance those questions of statins and HRT and so forth with their patient, we will have a system that can now deflate. The list prices can even out because they're not feeding all these rent seekers in the drug channel, and we can get to, I think, a lot investing in R&D in a rational way. Don't forget, a lot of R&D is determined by where you're going to be on the formulary. When you but who needs that?
Right.
It's not a great decision making. So I think we've made the turn. I think we are going to see some pretty cool stuff, with the development of AI systems that allow you to cross silos. Marty McCary makes this point. We have all these files. They're all paper, that tell us things that we want to know. We want to know if you have, DMD, what does the data tell us about, liver problems,
right?
Year 1, year 5, year 7, whatever. Those are the kinds of things that we have not been able to explore that we will be able to explore, which is, I think everybody should be very excited about that.
And I was going to add, and can we leverage, I think about the $4 trillion that's in the sector just floating out there kind of writ large. There's got to be two of that is clearly in play with respect to areas that we could access, redistribute, and again, let the innovation side make that kind of quantum leap that you're suggesting.
Yeah. Well, and we can't talk about that it's $5 trillion.
Okay.
We can't talk about the $5 trillion unless we're talking about the hospital sector, which gets about $2 trillion of it.
Right.
And one of the, I think, unsung policies, mostly because it was ignored, it's not been enforced on as well as it could be, and that is the hospital price transparency requirement. Mm-hmm. And just a PSA, if anybody out there is running a hospital, I want to know what you think about that. I really want to know what hospital administrators think about the hospital transparency, because if you were to actually look at the data, if you were to look at a hospital's discounted cash price versus what they're paid by the different insurance companies they contract with, you cannot, if you're in good health, let's say you're between 26 and 55, 60 if you are in good health, you can't look at your health insurance premiums as anything other than a tax. You're not getting much. The bottom 50% percentile spends about $1,300 a year on healthcare services. They spend about $12,000 a year on healthcare premiums. Why? Because something might happen, or we got to worry about the risk pools. You're sucking money out of somebody's paycheck and you're telling them they need to worry about the risk pools. They're worried about their risk pool. They're not really worried about UNH's risk pool.
Yeah, and their risk pool may include their mortgage, putting food on the table, making ends meet.
They can't buy houses. Well,
right.
Duh. We have this employer mandate says you have to enroll in health insurance if you are employed by, if your employer meets the requirements of the Affordable Care Act. And so you get into these stupid situations like that. And this is just another one of them. And when you look at the hospital price transparency data, which you have to conclude is, most healthcare can be purchased with cash if you are healthy. If you are not healthy, that's a different story, but you can do that. And there's the policy has an enormous amount of power. And the big question here is, how is this going to be, how is how's it going to roll out? How are the hospitals going to respond to it? Some seem to be embracing it. And, message to hospitals, embrace it, because it's going to be a question of you're going to be lashed to these insurance companies,
control your own destiny. Yeah. I always say control your own destiny, or someone else will certainly not mind controlling it for you. And I think be part of it, because the demographics, everything else, the financial side, it is not going to go, I think, in any other direction than what you're suggesting.
Right. And if you look at, there's this hospital here in Nashville, has a great cardiology program, really great. And there's another hospital here in town that's an academic medical center. There's no way for any normal person to know, a consumer to know, oh, this hospital here, who, by the way, happens to be the lowest cost provider in the market, they've got this program. I should go here. No, they go where the big academic, brand is. And it just doesn't have the best program. And there's no way for them to really talk about that. And otherwise they get, dirty, nasty looks and nasty grams from the academic medical center if they do. And when you start talking about price, you're going to start talking about quality. And when you talk about quality and consumer preference and stuff like that, you're going to have the whole world to be your oyster. Why you want to stick with, your insurance companies is for most things, routine things, I do not understand, which is why I want, call me, somebody send me an email. I want to understand why you would be opposed to embracing that policy.
The other piece, though, is getting back to just data and the source of truth and having some objectivity with respect to, again, we'll talk about program evaluation, like the two institutions that you're inferring right here. Boy, it would be great if we could really look at that objectively and comparatively. Early in my career, I ran a big heart program. It was very high volume, fantastic outcomes, but we were competing against a major academic center in the same, really within the 30-mile area. And although we did more cases, et cetera, and had better outcomes, the name recognition, the ability to get everything from, grants and even to attract, top tier all-star physicians and clinical staff was always, something that we had to work harder at because of the competition with that AMC.
Yeah. And if you think about, I'm working on this project on price transparency, and one of the questions we're trying to solve, hopefully with a hospital system here in the area, is, all right, how do you put those prices in context? Because I think that's a policy flaw. I think it's a policy flaw to say to a hospital, all right, post your prices, but don't put them in context. And one of the questions I have is, all right, how do you put that data in context? And I think that there's probably some quality metrics. And I look at those Press-Ganey surveys, and I'm always like, how about just one question? Would you recommend this place to a member of your family? That's all anybody needs to know.
Yeah, that's why I like that. As flawed as they are, net promoter scores, I think, are good. They're certainly better than directional.
Yeah, well, they're that old joke where if you want to find a good doctor, ask a nurse.
Right.
But make sure you ask the question the right way. So, if this was your mother, who would you call? And that's one of the things we've got to figure out. But I think it's a policy flaw that it isn't in the mandated disclosures under the hospital transparency requirements. And I think you could add other things to that, but yeah, that's where it's going. And it's not going to not go there. It's just, there's nothing to stop it from proceeding.
So Emily, we're going to wrap it up. We're literally wrapping up 2025 with you as one of our regulars. So this is the question for you. When you think about next year, 2026, and no, it's not crystal ball prognostication, but I'm going to ask you, give us, what's your top three when you think about the next year? What are the issues? What are the pressure points? What are the opportunities? What are the three things that you think we should, those of us who are engaged in and not only make our livelihoods, but are passionate about healthcare and the sector, what's on your radar screen?
I think number one, the pressure from the big health insurance companies is going to continue and probably get worse. And that is a function of particularly of Medicare populations getting older and sicker, and also the obvious inflation within the system. I don't think it's going to be as bad as the last 3 years, but the managed care organizations like UNH they've built their business around low inflation, a drug channel that provided all kinds of rebates and premium, downward pressure on premiums and so forth. So that is number one. Number two, I expect the rest of the drug companies to start acting like Lilly and marketing their brand and their service and beating the specialty mail order pharmacies every way they can for prescribed patients, and I think that is going to continue, and that's going to of course continue to collapse the drug channel where all the rebates are that control can depress, or on paper anyway, make it look like we're spending more money or less money than we are. And then I would say the third story is probably going to be biotech, and I think we're going to we're starting to see the benefits of these advanced computing models that can do things that humans can't do. And, using Marty McCary's example of the big file cabinet, big paper file cabinets, that this has a secret that you can't get to unless you go down into the basement and you find the file. And there's just not, resources for that. So I think we're going to really see that. I think that you're going to feel better about innovation and advances next year, this time, than you do now. I don't think you're going to feel the same way about the services side of the industry.
Well, wow. That's a lot. And I'm going to tell you, we're going to hold you to revisiting that after the new year, certainly. But great insights, great perspectives. And as usual, we are so pleased and happy that you are our regular in-resident, expert in so many different areas. Emily, have a great holiday season, fantastic Thanksgiving, and it's just a delight to have you.
Well, thanks. I'll look forward to coming back.
The opinions expressed by the host and guests are for informational purposes only and not associated with any companies or academic institutions. Please follow us wherever you listen to your podcasts, as well as our YouTube channel, Healthcare Nation Podcast. And if you have any questions or want to contact us, please reach out to healthcarenationpodcast.com.